Good morning. I'm going to start this morning by talking about a clinical case. I'm actually a nephrologist and have been seeing patients for more than 15 years now, largely as an on-site nephrologist for HIV clinics. And this is a patient that I saw recently in our clinic at Duke. This is a 60-year-old cisgender woman who was referred by her new HIV provider at Duke for management of chronic kidney disease. She had recently moved from Atlanta to be closer to her adult daughter, who felt that she wasn't taking the best care of herself, which actually is probably not so far from the truth. She had HIV that was diagnosed in 1993, shortly after her husband died of AIDS. At the time, she was asymptomatic. Her CD4 was over 200, and she was quite quickly started on AZT, and within a couple of years, was on a stable regimen of AZT, abacavir, and lopinavir-ritonavir that she took up until early in the pandemic, when she took advantage of the pandemic to take a little drug holiday. When she came back to reestablish care in early 2021, she was restarted on Biktarvy by her HIV provider there. In addition to the HIV, she also had a peripheral neuropathy that's self-treated with NSAIDs. This had recently been switched to PRN gabapentin by her new provider. And most importantly, she had hypertension that was diagnosed in the late 1990s. In the setting of a strong family history of hypertension. She declined medications until recently, feeling that she was really already taking too many things. She, sort of pointed to that old poster that we have on the wall of the handful of HIV drugs. But when she was switched to a fixed dose combination for ART, she was willing to take a fixed dose triamterene HCTZ, which seemed to be working relatively well for home blood pressure. At the time that I saw her, her office blood pressure was a little bit elevated with a systolic of 142, and her BMI was 35. She was otherwise a well-appearing woman, professionally dressed. She was going to work after our appointment with really no relevant findings on exam. Labs were notable for an undetectable HIV viral load, a CD4 over 500, and elevated total and LDL cholesterol. And also a hemoglobin A1C of 6%. So this hadn't yet been addressed. It was just noted at her recent primary care visit, her first visit to established primary care. So it looks like she has at least pre-diabetes, if not true diabetes. This is her first mention of this. Relevant to my visit, her primary care labs also were notable for a creatinine of 1.9. With the estimated glomerular filtration rate, or eGFR, of 30. Urinalysis was negative for protein, glucose, and cells. Her urine protein to creatinine and urine albumin to creatinine ratios were both normal. And just as a reminder for people who don't think about these often, these are both semi-quantitative, relatively simple measures, spot measures that give a pretty good estimate of 24-hour urine excretion of protein and albumin, respectively. Just a quick note on GFR, because this has been in the news a little bit in the last couple of years. Everybody here, I'm sure, is familiar with the fact that creatinine-based eGFR can be affected by diet, particularly either vegetarian, vegan diets, but also high intake of animal protein. It can be affected by muscle mass and by some medications. The most prominent ones being creatine, which is converted to creatinine after it's ingested, and cobicistat and some of the integrase inhibitors that actually inhibit the tubular secretion of creatinine. So sort of partially detaching it as a measure of glomerular filtration rate. There's also been some discussion about the inclusion of an adjustment factor for race in some of the older GFR estimates, and the newly derived CKD epi equation does not include any adjustment for race. So now this equation just includes age, sex, and creatinine. Obviously, there's still some issues there, and we'll come back to that. But and just as a reminder that cystatin C can be an alternative to creatinine. Cystatin C-based GFR estimates never included a race variable, so they actually are probably a little bit more accurate in the 2021 version. And they are not affected by muscle mass or by the same medications. Of course, it has its own limitations, probably the biggest one being that it's harder to get in at least in a timely fashion. It's a little bit more expensive. So it's a good, I think, one-time measure in patients where an accurate estimate of GFR is important. And just a quick reminder that the E in GFR stands for estimated. Only 12% of the derivation cohort for the CKD-EPI equation was over age 65. So for aging individuals, we're taking a little bit on faith. And there's very unclear guidance on GFR measurement or estimation in transgender individuals, in people who are extremes of age, of body size, in cirrhotics, in a number of different populations. So again, just, clinical judgment is always going to be important when interpreting a GFR. So what causes kidney disease in people with HIV? So I'm not going to really focus on HIV-related kidney disease today, although obviously this is an audience that's familiar with HIVAN and HIV-related immune complex kidney disease. Antiretroviral therapy has also been associated with toxicity. Obviously, Indinavir was really the classic one, but these are data from a kind of oldie but goodie study from 2010 from the DAD cohort that linked a number of protease inhibitors as well as TDF to increase risk of chronic kidney disease. So again, being aware of a history of use of these medications and ideally avoiding them in people who have kidney disease is important. And then I think probably most relevant to the aging population with HIV is traditional CKD risk factors, including genetic risk, diabetes, hypertension, and because I'm in the Stone Belt here in North Carolina, kidney stones as well. This is, again, another relatively old slide. This is an analysis that hopefully we're going to redo in the relatively near future, but these are data from the VAX cohort that essentially just showed that having both HIV and diabetes had an additive effect on kidney disease risk and kidney disease progression. So suggesting that our patients have increased risk compared to the general population. So optimal control of traditional CKD risk factors is probably the most important thing that we can do for our patients to prevent kidney disease progression or kidney disease development. So avoiding NSAIDs and other potential nephrotoxins. That can include, again, some of the antiretrovirals that I mentioned before when it's feasible. I always consider deprescribing proton pump inhibitors just based on an epidemiologic link with kidney disease risk when the indications are not so strong. Also lowering blood pressure targets. There are a couple of different sets of guidelines now, and I'm not going to go through the details, but again, the guidelines are all targeting lower blood pressures than we were in the past. And this would include first-line RAS blockade, angiotensin receptor blockers, or ACE inhibitors, particularly in anybody who's got diabetes or prediabetes, and in individuals with albuminuria. Optimal glycemic control in people with diabetes is essential. Ideally we would consider some of the newer agents like the SGLT2 inhibitors, again, especially in those with albuminuria, or in individuals who have concurrent cardiovascular disease. And this is actually a really important issue in people with chronic kidney disease. These are data from the VA health system, and essentially showing that the risk of atherosclerotic cardiovascular disease increases in a graded fashion across levels of GFR. So as the GFR declines from 60 to stage 3 CKD, a GFR between 30 and 60 and less than 30, these are individuals with stage 4 to 5 CKD, there's a sort of a dose response relationship with cardiovascular disease. And the same thing can be seen. Data were a little sparser for albuminuria, but the same relationship could be seen with increasing levels of albuminuria. So just a reminder that just like we think about people with diabetes as having increased cardiovascular risk, patients with kidney disease are in this same population. So cardiovascular risk modification is really essential in people with CKD. This may include consideration of a statin. For example, in our patient who has elevated lipids, it seems kind of like a no-brainer. We are getting data someday soon, hopefully from the REPRIEVE trial, which is obviously focused primarily on cardiovascular outcomes, but is also including an ancillary study that's collecting data on kidney disease outcomes. So we should have some data in the HIV population on the utility of statins for primary prevention of kidney disease. Smoking cessation obviously is always important in any population, but in particular in people with HIV and in individuals with chronic kidney disease. And then weight loss and increased activity to help with diabetes and hypertension control in our patient, potentially to help her control diabetes, maybe even without medications. So these are all really essential pieces of CKD care. Finally, I just wanted to spend one quick slide talking about advanced chronic kidney disease. I won't spend a lot of time talking about when to refer to nephrology, but I think that early referral is optimal in settings where this is feasible. This allows us to make sure we're not missing a treatable cause, something that we could potentially reverse either with medications or sometimes even a procedure. Also allows, in people with progressive disease, also allows for the management of complications, the two biggest ones being anemia and hyperparathyroidism, but obviously there also can be electrolyte abnormalities and other things where it's nice not to have to manage it on your own. And then finally, in those with really progressive disease, to make sure that we're prepared and that patients are educated about their options for management of end-stage kidney disease. And I'm not going to talk specifically about dialysis apart from it saying that people with HIV are candidates for any type of dialysis that's appropriate for their lifestyle, and that the earlier we get them ready, the less likely they are to wind up in the hospital to make that transition. Finally, kidney transplant in people with HIV, actually our patients have more options than everybody else. Their donor pool includes individuals who are hepatitis C positive, those are at least deceased donors, and individuals who are HIV positive, and that could be both deceased donors and potentially living donors who are carefully screened for their own risk of kidney disease. Because we're talking about aging people with HIV, I think it's important to note that there are often or almost always age limits for deceased donor transplant. 70 is a pretty common one. And that is just to make sure that we're using the organ pool wisely. So it makes, it's important to make sure that our, our older individuals who are getting close to that limit are referred early because there's still a possibility that they may get a preemptive transplant, meaning a transplant before they start dialysis. While they're still in the right age range. So again, early referral can really make a big difference in both medical outcomes and quality of life for these patients. And just a quick reminder that drug-drug interactions remain an issue, less so with less use of protease inhibitors, but again, cobicistat also has the same issue in terms of drug interactions with the calcineurin inhibitors used for transplant. So patients that come back to you after kidney transplant, really close communication with the transplant team or their nephrologist is really important. And I think I'm going to stop there and see if there are questions. Thanks so much.